Welcome to today's Explainer. Right now, we're stepping into the shoes of a medical detective to investigate a fascinating, seriously high-stakes medical mystery, hepatic encephalopathy. Imagine the human body as this incredibly complex, highly regulated machine. What happens when the primary filtration system, the liver, starts failing, and toxic exhaust basically bypasses all the safeguards, traveling straight up to the brain's mainframe? Well, you get a systemic breakdown, one that literally alters reality, behavior, and consciousness itself. So we're going to map out exactly how this happens, how to spot it, and most importantly, how to stop it.
But before we even look at the pathology, I want you to remember three words: reversible, reversible, reversible. That is the absolute core mantra from our source material today. When a patient presents with sudden confusion, altered sleep, or even falls into a full-blown coma due to liver disease, it can look terrifying. It looks like an inevitable terminal decline. But it's not. Hepatic encephalopathy is a highly treatable syndrome. It's an empowering puzzle for the medical detective to solve, because if you can find the underlying trigger and clear out those toxins, you can absolutely bring that patient back.
Okay, let's dive into this. Here is our quick syllabus for today's investigation. 1. The reversible brain syndrome. 2. The ammonia culprit. 3. Hunting for triggers. 4. Grading the encephalopathy. And finally, 5. The lactulose solution. Let's get started. So Section 1, the reversible brain syndrome. Let's establish the basic facts of our crime scene here.
What exactly are we dealing with? By definition, hepatic encephalopathy, you might also hear it called portosystemic encephalopathy, is a reversible syndrome of impaired brain function. It occurs specifically in patients dealing with liver dysfunction and portal hypertension. If you're studying or practicing medicine, this is an absolute bread and butter complication of portal hypertension. It's a direct consequence of a failing liver that just can't clear toxins anymore, allowing them to pile up and completely disrupt the central nervous system.
Now here's a really high-yield exam pearl. You should know there are 3 distinct types of this syndrome. Type A is associated with acute fulminant hepatic failure. In these cases, severe cerebral edema is a major complication and, unfortunately, a very common cause of death. Type T is associated with TIPS. That's a surgically created portosystemic shunt. But for our purposes today, we're really zoning in on Type C. Type C is the most common presentation by far, occurring in the setting of chronic cirrhosis with portal hypertension.
Moving right along to Section 2, the ammonia culprit.
We know the setting, so let's see how this actually builds. We're going to track our main culprit, ammonia, on its journey from the gut straight to the brain. Step 1 starts with a failed urea cycle in a highly dysfunctional liver, meaning the body just can't detoxify ammonia the way it normally would. Step 2, because of portal hypertension, blood flow develops collateral shunts. These portal systemic shunts act like a bypass highway, right? They allow ammonia to skip the liver entirely and flood into the systemic circulation. Step 3. Where's all this ammonia even coming from? Well, a massive amount is generated by colonic bacteria acting on proteins down in the gut. And finally, step 4, this totally unchecked ammonia crosses the blood-brain barrier and arrives at the astrocytes in the brain, where the real damage goes down.
Now, what's literally mind-blowing is exactly what happens when that ammonia arrives at the crime scene. The main site of injury is the astrocyte, specifically forming what are known as Alzheimer's type 2 astrocytes. When ammonia enters, it immediately combines with the brain stores of glutamate to form glutamine. This excess glutamine is highly toxic. It basically acts as a giant osmotic sponge, causing catastrophic swelling of the astrocyte. Plus, because the brain is using up all its glutamate to make that glutamine, total glutamate stores become totally depleted. Paradoxically, cerebral spinal fluid glutamate actually spikes, which hyperactivates NMDA receptors and triggers this massive secondary neuronal excitotoxicity. It's basically a massive, multi-level chemical pileup.
Let me just break the fourth wall for a second here. While ammonia is absolutely the hitmaker and the star of the show, it totally has accomplices. And exam questions love to test your knowledge on them. Ammonia doesn't act alone. Other neurotoxins implicated in this syndrome include mercaptins, phenols, aromatic amino acids, manganese, GABA, octopamine, and free fatty acids. If you're cramming for a test, definitely pay special attention to manganese, aromatic amino acids, and mercaptins, because our source material notes these are highly tested accomplices in the pathogenesis.
All right, Section 3, hunting for triggers.
We've got our suspects, but what actually arms them? Let's move to the most critical action for any clinician handling these cases: hunting for the precipitants or the triggers that push a totally stable liver patient into acute encephalopathy. To figure that out, we have to solve a quick biochemical riddle. Let me pose a question to you.
Why does alkalosis worsen hepatic encephalopathy? Think about it for a second. The body's pH balance shifts just slightly basic, and suddenly brain function rapidly deteriorates. Why?
And this chemical relationship brilliantly illustrates the answer. It's all about chemical equilibrium, right? Ammonia plus a hydrogen ion shifts back and forth into ammonium. Side A is NH3, pure ammonia. It is highly toxic and easily crosses right into the brain. Side B is NH4+, ammonium. Now, ammonium has a charge, so it cannot cross membranes. It stays harmlessly trapped down in the colon waiting to be excreted. Alkalosis means a lack of hydrogen ions. If you reduce the available H+, the chemical equilibrium shifts violently to the left, favoring the toxic NH3. Because of this, our source material makes a very counterintuitive but totally vital teaching point. In this narrow chemical context, at all costs, we actually want acidosis.
Knowing that, we can put together our suspect board of triggers. Your job is to search for these immediately. The list includes things that increase ammonia production, right? Like dietary protein overload, constipation, or receiving a blood transfusion. It also includes things that cause alkalosis, like hypokalemia, hypovolemia, dehydration, or diuretic use. But listen, if you take absolutely nothing else away from this section, strongly emphasize upper GI hemorrhage and sepsis. These are repeatedly highlighted as the two most critical, high-yield triggers a medical detective has to look out for when a patient shows up with encephalopathy.
That brings us to Section 4, grading the encephalopathy. Once we've stabilized the patient and started hunting for those triggers, we've got to establish a baseline. We do this using the West Haven criteria. It's a really crucial tool that tracks symptom escalation, and it splits into covert and overt encephalopathy. Minimal HE is covert. The patient looks perfectly normal clinically, and deficits are only caught on fine psychometric exams, like the number connection test. Grade 1 brings altered sleep rhythms and anxiety. Grade 2 is where it becomes very overt. You're going to see clear personality changes, disorientation, and the onset of asterexis. By grade 3, the patient is in a semi-stupor with bizarre behavior and rigidity, though they still respond to pain. And finally, grade 4 is a coma, classically associated with triphasic waves on an EEG.
Since asterexis is the hallmark physical sign that pops up right at grade 2, let me share an insider exam-focused pearl on how to actually test for it. The common method you often see demonstrated in the wards is actually incorrect. The proper method is to have the patient keep their hands on a level surface, dorsiflex their wrists, and spread their fingers. A failure to maintain this posture indicates asterexis. But be warned, while it's a fantastic clue, asterexis is highly nonspecific. You can see it in renal failure, respiratory failure, hypoglycemia, and hypomagnesemia, not just liver disease.
And finally, Section 5, the lactulose solution.
We've identified the culprit, found the triggers, and graded the severity. Now the source material gives our primary treatment a very fitting title, the Kingmaker. We are talking about the lactulose bowel wash and lactulose enemas. This is the ultimate, most practical bedside treatment available. It is your absolute first-line practical management tool, and it's typically administered at least 3 to 4 times a day.
So, the really crucial point here is understanding exactly why this simple syrup is so incredibly effective. Lactulose basically uses a multi-pronged attack to disarm ammonia. First, it decreases colonic pH. Remember our chemical riddle? Lowering the pH creates an acidic environment, which forces toxic NH3 to shift into harmless, non-absorbable NH4+. Second, colonic bacteria ferment lactulose into volatile fatty acids, which those bacteria then use for themselves, soaking up even more nitrogen and reducing the overall ammonia burden. And third, it has a powerful laxative effect, rapidly clearing all those ammonia-generating substrates right out of the gastrointestinal tract.
Now, while lactulose is the kingmaker, it definitely has backup. Think of these guys as the add-on squad. Rifaximin is a really common antibiotic adjunct used to just wipe out the ammonia-producing gut bacteria. You might also see acarbose, branched-chain amino acids like LOLA, or even sodium benzoate used to help manage nitrogen levels. But it is vital to reinforce that these are merely adjuncts. They do not, and I mean do not, replace the primary lactulose intervention and the aggressive hunt for the underlying trigger.
Before we officially close the case file today, I have to issue a massive clinical warning for you bedside medical detectives out there. Do not, under almost any circumstances, use sedative or CNS drugs in a patient with suspected hepatic encephalopathy. Because these patients are often agitated, anxious, or exhibiting really bizarre behavior in those early grades, the temptation to sedate them is incredibly high. but doing so will actively worsen their encephalopathy via GABA-related effects, plunging them much deeper into a coma.
Well, we've reached the end of our explainer. We've learned that by finding the trigger and deploying lactulose, we can literally pull a patient back from the brink. It's a phenomenal medical triumph. But I want to leave you with a sobering clinical reality to think about. Reversing hepatic encephalopathy is a major victory for today, but what happens tomorrow if the underlying cirrhosis is permanent and a liver transplant simply isn't an option? Those toxins will just keep building. Solving the mystery of the reversible brain syndrome is just one battle in the much larger, much tougher war of end-stage liver disease. Keep exploring, keep questioning, and thank you so much for joining me on this investigation today.